Hello everyone, my name is Emily Kosick and I'm the Knowledge Manager for the Canadian Institute for Public Safety Research and Treatment. I want to welcome you to today's session, which is called Suicide and Public Safety Personnel, What We Know, What We Think We Know, and What We Don't Know. Before we get started today, there are just a few housekeeping things I want to go through. The first is that you are all in listen-only mode, and that is so that we can limit feedback and noise during the presentation. Today's session is being recorded, and you'll be sent a copy tomorrow, so if you miss anything, you can watch it again. Just so you know, the GoToWebinar launch window can be blocked by some organizations, so if you're having trouble hearing or seeing, you may have to join us by phone or watch the video later. We will be looking for audience questions at the end of the session, so please send us your questions either through the question box, or you can wait until the end of the session and raise your hand, and I can unmute you to ask your question. If you are asking your question by being unmuted, we do ask that you keep the question short, just so it's easy for Dr. Hatcher to answer your question. Now, I am going to introduce our speaker for today. Dr. Simon Hatcher is the acting chair of the Department of Psychiatry at the University of Ottawa. He is also the chair of Suicide Subcommittee and a number of many other things, too long to list here. Dr. Hatcher, I want to thank you for being here today.
Thank you very much. Yep.
I'll go ahead and turn over the presentation sharing to you so that you can put up your presentation.
Okay. So that's good.
Yeah, I can see it clearly. Yeah.
Okay. Well, thanks everybody for giving up your time this lunchtime. Just by way of introduction, I'm a psychiatrist. I work in Ottawa at the Ottawa Hospital and in Ottawa Inner City Health. And part of my work at the Ottawa Hospital is to run a first responder clinic, which complements our research program in the research lab that we do at the Ottawa Hospital on first responder mental health. So that's my sort of qualification for being here. In terms of background, I'm originally from England, but spent most of my adult life in New Zealand, so I've got a weird accent and I don't speak Canadian yet, so I apologize. If you don't understand anything I say, please let me know in the chat or the question, and we'll see what we can do from there. So what I was going to do, I'll tell you what it's going to do. This is described as a town hall, and I had no idea what a town hall meeting was. So I had to look it up. Apparently, the first town hall meeting took place in 1633 in Massachusetts. Not many people know that. So town halls are where politicians try to connect with their constituents. It's not a phrase that we have in New Zealand English or English. It's very much a Canadian English or US English. So I thought this is no good me going to be talking for 60 minutes. What I'm going to do is I'm going to talk for 40 minutes maximum. If you want to ask questions or make comments through the talk, please do so. I'll try and attend to them or answer them as we go along if they're urgent. Otherwise, I'll address them at the end or in writing after the meeting. So I'm going to talk for about 30-40 minutes, and then we're going to have the last 20 to 30 minutes for questions and discussion. So I hope that's what you're hoping for. One of the things to mention talking about suicide is that suicide is a difficult subject. It can be really difficult talking about suicide, and it can provoke quite strong feelings, especially in this format where people are dialing in from home or locations where they may be isolated just because of the nature of doing this sort of thing, and this may provoke strong feelings. As I understand it, people are dialing in from all over Canada, so I can't give you specific local numbers, but there is a Canada Suicide Prevention Service who have a Canada-wide number, except in Quebec. That's a slightly different number. Or there's the Canadian Association for Suicide Prevention, CASP, also have a list of resources at their site. So that's the caveat we're talking about suicide. So what I'm going to do is firstly just do sort of suicide 101, and then I'm going to talk far more specifically about suicide in public safety personnel. So to start with, how do we think about suicide? It might seem a sort of strange way to begin, but it's quite important because it really reflects a lot of how we manage, talk, and think about the problem of suicide. So, as you may or may not know, suicide and trying to kill yourself was only decriminalised in Canada in 1972. And actually, in most countries in the world, it is still against the law to try and kill yourself. In the 19th century, in the UK, the penalty for trying to kill yourself was death. The last person to be hung for attempted suicide was, I think, in the 1830s. So, and it was only decriminalised in the UK in the early 1960s. The reason for this is because suicide was thought to be done by bad people. It was a moral problem, and it was against, and you know, that morality got incorporated into law. And there's various reasons for that, which I'm not going to go into, but it's a very interesting history about why suicide became illegal. And the reason it's important in the present day is because there's still a hangover from that. And also, if you think about the problem of suicide globally, this is actually true in most countries around the world, in that trying to die by suicide is still illegal. So up until very recently, people used to refer to committing suicide, and the word commit comes from the fact that it was something that was illegal, and nowadays patient advocates much prefer us to use the phrase die by suicide rather than commit suicide. But that's a hangover from the language. But also you get some of the hangover from that in the laws and the way that coroners approach the problem of suicide. So, and also you sometimes get this attitude, you know, people report it if they go to the emergency department, not so much as they used to, but you know, certainly people who have attempted suicide who end up in the emergency department or other parts of medical care will often relate you know, maybe not being treated that well, and that's a hangover from suicide being done by bad people. So it's still relevant in the present day. The second way to think about suicide is that it's a social problem. It's caused by social difficulties. And in fact, the first textbook of sociology was written by Émile Durkheim, who was a French academic in the late 19th century. And the subtitle was A Textbook of Sociology. And this basically launched the whole discipline of sociology. And Durkheim described how there were different suicide rates in different countries at different times, and how these changed and were linked to, at the time, religious practices and what he called anomie, which is something along the lines of feeling disconnected from society. And that's a very seminal book. These days, the commonest way to think about suicide is that it's a medical problem, which is why I, a doctor, am talking to you about it. And it is caused and linked to mental illness. One of the remarkable things about suicide is that if you do what is called a psychological autopsy, which is where you look at the evidence for whether people had a mental illness before they died, fairly consistently around the world, between about 80 to 90% of people who died by suicide will have fairly good evidence they had a mental illness before they died. Now, that still leaves 10 to 20%, and there are some subgroups where the evidence is less strong that mental illness is an issue prior to suicide. And it may be, we don't know, but it may be that first responders, PSPs, may be one of those subgroups where the link between mental illness and suicide isn't necessarily as clear as it is in subgroups. We don't know that, but that's certainly a possibility. So those are the three ways we think that people traditionally think about suicide. It's done by bad people, it's a social problem, or it's a medical problem. So that's how we think of suicide. Before we go on any further, what is a suicide? What is a suicide? So a suicide is an opinion, it's a legal finding. It's an opinion of a coroner who may not be medically trained in Canada, or a medical examiner, which is determined by the interpretation of evidence. Okay? So a suicide is a finding that a coroner or a medical examiner makes based on their opinion of the interpretation of the evidence. So there are different rules for determining whether a death is a suicide in different provinces and different countries. Okay? In some provinces, it's the guidance is more restrictive, and other provinces it's obviously less restrictive. And coroners have to find whether an unexpected death can be natural, an accident, a suicide, or a homicide, or undetermined. And depending on which coroner's jurisdiction you look at, the ratio that if you look at some of the undetermined deaths in other jurisdictions, they might be considered a suicide and vice versa. And in fact, when some people look at changes in suicides over time, they may or may not include undetermined deaths with them as well, just because of that overlap. And of course, some people on this call may be police who work for coroners, for instance, who have a role in investigating these deaths. So, and the picture. I'll put the picture in there because it's Toronto. Yeah, Toronto is full of nice new buildings, and this is the coroner's office in Toronto. So, what's the current situation in Canada with suicide at the moment? There are about 11 people a day die of suicide in Canada. Okay, so that's about 1 every 2 hours, maybe slightly less than that. That's the current situation, and it's been like that for about a decade, maybe even longer. Somebody told me the other day that suicide rate's increasing. It actually isn't in Canada. It's been about the same for the last, at least the last decade. In 2019, there were just over 4,000 suicides. Interestingly, in 2020, with COVID-19, that's dropped by about 10% to 3,500. Those are provisional figures. The reason they're provisional figures is coroners take time with some deaths to decide whether they're a suicide or not. And these death investigations can take months and sometimes years. So that's why recent figures are often provisional. Okay. The other thing about suicide is it's unusual. The rate is about 11 per 100,000 population. It's a rare catastrophic event. Who dies by suicide in Canada is fairly typical of rich Western countries, in that about 75% are men, and it's middle-aged men who die by suicide. About half of all suicides are men aged 30 to 65. Maybe I'm stretching the definition of middle-aged there, but I think you get the point that this is not a problem of necessarily youth. It's a problem in men. So, you know, it's not necessarily your young, upset university student who is typical of somebody who dies by suicide. It's much more likely to be your older male who's drunk a bit, banging along his pickup truck along the back roads somewhere, who might be more of your typical person who dies by suicide in Canada. And that's fairly typical, as I said, of rich world countries. It's exactly the same picture in New Zealand when I was working there. So that's the current state of suicide in Canada. It's a rare persistent problem that happens in men, and mainly middle-aged men. So, one of the things to say is about the prevention of rare, unpredictable events. So I'm going to talk about prevention now. There's essentially two ways of thinking about this. One way is you try and identify people at high risk and provide more resources for them. The trouble with that is it's really hard to pick who's going to be at high risk of these rare, unpredictable events happening. The other way is to think of things in systems. So when you fly, and it's much safer flying than driving to the airport, they don't try and pick out which plane that day is most at risk of crashing and provide far more resources for that plane, because they'd be wrong most of the time. What they do is they have a system which ensures that the right thing is done every time. And on the right-hand side here, you'll see the well-known James Reason Swiss cheese model, which is that bad things only happen when, by coincidence or bad design, all the holes in the various things which are supposed to prevent bad things happening align. Okay. So, when we talk about suicide in the general population, these are usually the core components. And you'll notice that the first four are around thinking about suicide as a mental illness. So it's about, the first thing that is done is helping improving the identification and treatment of depression in primary care. So when you go to your nurse practitioner, when you go to your family doctor, when you go to an emergency department, things can get done to improve and detect people who are depressed, because depression is the disorder which is most commonly associated with suicide. About 70% of people who die by suicide are depressed. So doing something in primary care or other bits of their health system that people come in contact with is important at detecting those who are high risk and doing something about it. Second thing, which is, this is one of the things R2MR does, for instance, is increase awareness of depression and mental illness in the community to improve knowledge and decrease stigma. So it's about giving people information, it's about educating people about mental health, mental illness, and making people aware of what the warning signs may be that people may be becoming depressed or unwell. Third thing is, well, the third and fourth thing is training gatekeepers. So those people who are likely to come into contact with people who may be distressed. So in public safety personnel, it may be peer support organisations, peer supporters, and training them. And the most important part of the training is knowing what to do with the answer to the question, are you feeling suicidal? That's often one of the reasons why people don't ask difficult questions, is they don't know what to do with the answers. So the training helps people to know how to answer those questions, how to have a conversation around, you know, are you usually like this? Is this normal for you, etc., etc. The second thing in this sort of territory is managing media and managing publicity. Journalists hate this because it's one of those rare areas where actually they interpret this as media restrictions and people trying to muscle the media, which is an understandable perception. But there is also relatively good evidence, it's pretty good evidence, that giving the wrong sort of publicity to suicides can increase the rate of suicides and encourage copycat and contagion. So that's why having media guidelines about reporting on suicides is important. And then when you get to care, It's better care for high-risk groups, so people who've already presented to hospital who say they're suicidal or have actually attempted suicide, people who are having treatment for depression, and particular occupations may have particular high-risk groups. So those are the four sort of traditional core components of any suicide prevention strategy, whether you do it in the military, whether you do it in the general population, whether you do it in hospitals. Those are the sort of things that people will talk about for suicide prevention. But there's also managing other risk factors, and this is probably becoming more important in modern suicide prevention, is identifying what other risk factors may be there and trying to manage them. So I'll talk a bit about this later on, but managing some of the characteristics of organizations which might make people more suicidal, for instance. Managing inequity, if you do it in the general population, for instance. Managing even micro issues at a local level, like access to green spaces. Those are all connected to increased risk. So managing those is becoming more important. The psychology of suicide. So if you just want to copy this down, no, don't really. This is from a model which has got an unnecessarily complicated name. The take-home message from this is that people who die by suicide feel something bad has happened to them, usually involving some sort of loss. They feel trapped and they feel hopeless, and they've got access to the means to die. That's what this tells you, this particular diagram. So as a clinician, one of my jobs in when I see suicidal people is to help them feel less trapped and less hopeless. Going into this in a bit more detail, on the left-hand side, you'll see that there are various longer-term risk factors, like life events and stuff about the environment and stuff that's happened in people's previous life, which might make them more likely to get into a territory where they may be suicidal. And then there's, closer to the event, there's the things which push you into thinking a bit more about suicide. So often events which involve defeat and humiliation, or threat to self, people with poor problem-solving skills at more at risk of suicide, people feeling trapped, as I said, because when you see people who are suicidal, one of the things that really struck me when I first started seeing a lot of suicidal people is that from their point of view, what they're doing is really logical. It really makes sense. Trying to moderate that's important, and that can lead to suicidal ideas as a way of escaping from a situation where people feel trapped and hopeless. And if people have the means or a past history of doing this, that again pushes up the risk. So that's the psychology of suicide. Basically, it revolves around feeling trapped and hopeless and loss, essentially. That's the general model. There's exceptions to that, but that's the general way of thinking about it. So I'm going to focus a bit more now on public safety personnel suicides. What are the general risk factors? Well, most public safety personnel are male and middle-aged, so that's a risk factor right there. Protective factors, before going on to some of the more specific factors, protective factors are often what comes with being involved in public safety is a strong sense of belonging to an organization. And with that sense of belonging becomes social support and camaraderie. That feeling part of a group is really important, and the social support that goes with it is really important as protective factors. And the other thing is that you get as working as a first responder, public safety personnel, is a strong sense of purpose and duty. And those are all important protective factors. Now, one of the things I often ask people who I see in a first responder clinic who have been suicidal or feeling depressed and they're off work is, do they still go to barbecues of friends from work? You know, are they still getting that social support? Do they still have do they still get invited to work barbie? So that's important. People who have that sense of social support, that's a really important protective factor. Although the converse is often true as well. So what about the unique risk factors in public safety personnel suicides? Well, there's access to weapons and other lethal methods. You know, if you know, people have guns, people have access to medications which are lethal, people have access to weapons, that increases your risk. Shift work is often undercounted. It messes up your sleeping. That increases your risk of suicide. Not a great deal, but it certainly does increase it. And it's much harder to recover from depression if you're doing shift work. There's a culture amongst public safety personnel around helping others rather than personal needs. Being seen to be weak, being seen to need personal help means you're just like the people you go out to help, and that is not a good thing. Showing what is perceived as weakness is risky. And of course, there's the occupational exposure to trauma. One of the jobs about one of the ways you can define almost PSP's work is that the job is witnessing a lot of trauma and at times being a victim of it as well. And again, that increases your risk. And then you come to two of the issues which are, I think, much more specific to PSP workplaces. Stigma around being seen to be asking for help with psychological problems. And police will often tell me that they don't want to be identified as you know, or to be lumped with the people that they see every day on the streets who are mentally ill, who, you know, just appear mad. Paramedics say, I don't want to be the, I'm not like the person who's fighting in the back of the ambulance after they've taken an overdose. And that can lead to significant stigma in the workplace, which means that not only is there discouragement from talking about mental illness, but if you do, it can be actively disparaged. You know, you're the broken toy, for instance, and other familiar phrases. And the other thing about workplaces, they can often they go down this spiral of being quite toxic. And one of the, I was on the coroner's inquiry into suicides in Ontario, into the OPP, and one of the things that was striking in the cases that we reviewed there was how well that a number of the people that we reviewed were being disciplined at the time, and how that was a significant factor in their suicides, when we know that from notes that they left or comments they made to other people. And that certainly seems to be a very high risk time for suicides in public safety personnel. And that goes to the first part of this slide, which is around being part of the herd or being out of the herd. What you learn as a first responder is that being a first responder is everything. Identity is important, and the uniform, and there's something very. The uniform isn't just symbolic; it's real. And you know, whilst you're in the herd, you're great. You're protected by the herd, but once you're out, once you're threatened with being out, out goes the identity. Well, the identity becomes under threat, and you lose the protection of the herd, and that's really significant. What people tell me about what's important in pushing people towards suicide. The other thing that's important is, especially in the workplace context, is betrayal and humiliation. It's not something you see very much in the academic world, in the academic literature on this, but if you read people's personal accounts of this, of suicide and depression, who've either been in the military or PSPs, this seems to be a really big thing, is that they feel betrayed by their work, or that the work, when it comes to them, doesn't walk the talk. They talk about being a caring organisation, they talk about being a service organisation which is dedicated to public service, but when it comes down to it, they don't walk the talk. So I mean, I've seen several police officers who feel betrayed when the justice system lets them down. You know, one person I knew had a child who was assaulted, and I don't even know if it went to court. And other more serious examples of that. And then there's humiliation as well. People will tell me locally that there's a walk of humiliation that goes past human resources in the organisation to EAP. So everybody in human resources knows that you're going to go to EAP. And there are that, and there's other more important, more significant examples of humiliation as well. The uniform seems to be really important, because one of the things that I see when I see first responders, that the thing that always provokes the strongest feeling when I see people is that sense of betrayal, and people will tell me what they want to do with the uniform. So one person told me, I want to take it off, throw it on the floor, I'm going to pee on it, and then I'm going to set it alight. I mean, he clearly wasn't a firefighter, but it says something about how you know, the symbol of the uniform, the identity around the uniform, is very important. And one of the things that we're working on is actually developing a way of measuring this sense of betrayal and humiliation, because it seems to be clinically quite important in on the pathway to depression, suicide, and serious consequences from that. What we think we know. One of the things we think we know is that first responders, public safety personnel have higher rates of suicide than the general population. It's actually, the jury's still out on this. The evidence is variable and hard, and it's hard to know the most appropriate comparison group. If you look at, you know, studies done over the last 20 years, there's a variety. Most find that PSPs have about the same or slightly higher rates than the general population, and a few find that PSPs have a lower rate. So there's that variability. And of course, you've got to remember that suicide is a rare and unpredictable event. It doesn't happen very often. When it does, we remember it, and it's a tragedy, but it's still relatively rare. So small numbers can skew figures quite easily. And the other thing is, it's hard to know who the most appropriate comparison group is, because first responders are employed, they're a healthy worker group, and should they be compared to the general population, which includes people who aren't working, includes people who includes both men and women, and populations who are at lower risk. It's even if first responders have the same suicide rate as the general population, that's probably not a good thing, because they are a healthy group, they're employed, they're fit usually, and they're selected, they're quite a selected bunch. So we're not entirely sure about how rates of suicide in public safety personnel match up to the general population and what the appropriate comparison group should be. The other thing we think we can know is we can predict who is going to die by suicide. And the simple answer is we can't. You can't predict individuals who are going to die by suicide. You might be able to say something about populations, but you cannot, there is no useful, accurate way in which we can predict which individuals are going to die by suicide. That's because it's such a rare event. What you end up doing is you end up having so many false positives that it's just not useful. What we don't know. Surprisingly, nobody knows how many public safety personnel die by suicide in Canada. We're doing a study at the moment looking at deaths in first responders in Ontario between the beginning of 2014 and the end of 2018. And we're looking at coroner's records and we're comparing them to matched controls from the same coroner's records. The difficulty with this study is identifying in those records which first responders died by suicide, because there's no electronic way in which you can look them up. There's actually no way of going into the Toronto coroner's office, which contains all the records for Ontario, and saying, can you identify for me first responders suicide records that I can go off and just get information from and compare them to general population, because they have no way of identifying who is first responders in those records. People have tried to keep records in the past. There may be people keeping records now that I don't know about, but the bottom line is we don't know how many first responders, how many public safety personnel die by suicide in Canada. And then do you include people who've retired? Again, it's difficult, because that would include people who spent 5 years as a volunteer firefighter in the 20s, as well as people who spent a 35-40 year career as a first responder before retiring. We don't know about the role of contagion. If you look at the deaths of some first responder organizations, it looks like there are clusters of first responders who die by suicide. But we don't know. We don't know that. That hasn't really been looked at. This might be one of the things which makes suicide in first responders unique. We also don't know how to prevent chronic exposure to trauma causing mental illness, causing mental injuries. We don't know how to do that yet. We don't know how to respond well to constantly witnessing trauma. There's various things that you can do, but there's really little evidence about what works and what doesn't work. So, having said that, what would a suicide prevention and public safety personnel look like? So I divided this up into 3 groups. The first group, the first 3 bullet points are, if you like, primary prevention. It's before people get to being recognized as being at high risk. The second group is people who are they've either sought care or they've been identified somewhere as high risk. And the third group is, well, what do you do after a suicide? So suicide prevention and public safety personnel might look something like this. And this is better access, screening, and aware for mental disorders. So with health checkups, with making sure that people have a family doctor as part of their employment, all those sorts of things are really important, and training people who see first responders to be aware of the importance of screening for things like depression and suicidal thinking. Training gatekeepers, peer supporters, helping them know what questions to ask and what resources are available for people who seek their help is an important part of suicide prevention. And addressing non-medical factors in organizations like toxic organizations, stigma, and changing the culture. One of the suggestions that I've heard from police around changing the culture is that when you go for promotion, having questions there about how did you manage mental health in your last platoon or last organization that you worked in, for example, so that it becomes important and part of it being the culture. There are organizations which are well run and organizations which are not. And a fruitful area of research, I think, is to look at the differences in those organisations around which are considered toxic and which are considered good organisations. And the good ones seem to be characterised by this notion that they've got your back. And toxic organisations seem to prioritise other things. The next two pieces are around better access to care, better treatment for first responders, so that treatment isn't delayed, it's easy to get into, and they get treatment which has got some evidence that actually works. And the second thing is about managing transitions between work and non-work better. And I've lost count of the number of people I've seen who are first responders, who as soon as they go off work, nobody contacts them anymore. They're completely out of the herd. And I think we could probably manage things better. And then getting back to work is really hard. There seems to be all sorts of barriers to getting back to work in some organisations. So you're either full on or full off. There doesn't seem any halfway house. And of course, the longer you're off work, the longer you're going to be off work. So managing those transitions between work and non-work is better. Now, and giving people training, giving organisations training about, well, what do you say to somebody who's off work, who's suffering from PTSD or depression? And how do you manage that conversation? Those sort of things seem to be quite important around managing those transitions, so people don't feel abandoned and lose their support network. And then if one of these tragedies does occur, well, what do you do after a suicide? How do you stop it spreading to other people? What do you do? This is not something that's unique to first responders or public safety personnel. I mean, the same thing happens in schools, for instance. What do you do if there's a suicide in the school? In public safety personnel, well, do you have an honour guard for somebody who dies by suicide? Is it counted as a death in service? How are they memorialised, for instance? How do you manage the media? How do you manage the family of a person who's died by suicide? How do you manage the people in the organisation who knew the person? I think it's got a hot button issue, and as part of the SIPSA suicide subcommittee, which sounds really exciting, but probably is quite important, one of the things we're going to do in the first year is to come up with guidelines about what to do after a suicide in public safety personnel organisations. And if people want to contribute that and have an opinion, I'd be really delighted to hear from them. We need to probably improve media reporting after first responder suicides. My impression, and again, it's only my impression, we're actually doing a study to look at this, is that media reporting after first responder suicides doesn't adhere to media guidelines, or if it does, it's much less frequently than the general population. So that is something that I think can be improved. And as I've hinted at before, better monitoring of suicides by public safety personnel. Because we don't know we don't know rates of suicide in public safety personnel. We can't track it over time. It's hard to know what are the important risk factors. So actually having coroners identifying their records, having some easy way to identify in the records who are first responders or public safety personnel, I think is actually quite important as a strategy going forward in suicide prevention. It's something we recommended in the coroner's OPP report in Ontario, and it's something that we're going to be pressing to do on a nationwide basis as part of the SIPSA suicide group. So that's me finished talking. I just want to re-emphasize that talking can be difficult. It can provoke strong feelings. Here's some numbers if you do need to talk to anybody about this subject after this talk, and I'll be delighted to take some questions or comments or engage in discussion.
Okay, wonderful. So we have had some questions come in throughout this presentation. I do also encourage people, if you have a question that you want to ask, you can raise your hand and I can unmute you. But we'll start with a question now. Here's kind of a bit of a fun question for you. One asks, He has no problem in understanding you. He says that you sound a bit like Michael Caine, and he wonders what area that you're from originally in England, and if it's perhaps near, I believe, Rosslethwaite is how you'd say that in English language, where Michael Caine is from.
So can I stop sharing my screen so we'll actually?
Yes, you can. Yeah, go ahead. Okay. I'll change it for you. Yeah.
Yeah, so people actually see me. I'm originally from Devon. Worked in Yorkshire for a long time. I trained in Yorkshire, and I'm in New Zealand. I'm a Jaffa, which is just another effing Aucklander. So there you
go. Next question is: overdoses are really up. Is an overdose considered a form of suicide? And maybe that's why the rate overall is down if it's not considered a suicide.
So we're talking post-COVID here?
I think we're talking about during COVID, why the 2020 numbers might be so much lower than the 2019 numbers. Yeah,
so the relationship between overdoses, attempt and suicide is they're separate but overlapping phenomena. If you look at the epidemiology, sort of who does it and who does it and how, people who take overdoses are generally different to people who die by suicide. People who die by suicide, as I mentioned, they tend to be middle-aged men, whereas people who take overdoses tend to be younger women. So that they're overlapping but separate phenomena. Attempted suicide, however you want to, whatever language you want to use to describe it, is the biggest risk factor for subsequent suicide. It blows everything else out of the park. It increases your risk in later life by a large amount, and you can imagine why. Relationship to COVID, it's really interesting. We wrote a paper on suicide rates and past epidemics, and what you find is that suicide rates didn't increase or went down a little bit during epidemics, but then when it gets towards the end, they bump up a little bit. It's a bit like people are waiting for things to change, to be different after we've been locked down, and they find out that everything goes back to normal, and people just get despair again, and it goes up again. If you look at suicides in the United States, after the Spanish flu, they didn't really go up very much, except at the end, and then they went down again. They became less after the Spanish flu. They were lower after the Spanish flu than they were before it, and that's because they introduced prohibition about the same time. So people stopped drinking. Drinking is another risk factor. And one of the things that tells you is that social forces are quite important in affecting suicide rates.
Okay. Our next question is: do you think that PSP employers, should pay for annual psychological check-ins with an occupationally aware mental health professional, in order to identify warning signs and connect people to support prior to having an issue?
Yeah, I know this is a really popular notion amongst first responders and public safety personnel, and I don't know. And the reason I don't know is because nobody knows. Nobody's actually done a study to actually find out if that helps. There are practical difficulties if you mandate it. If you pay for it, people often have in-house psychologists who might want to go outside. It's I think the way forward is actually build it into wellness programs, so that it's part of peak performance, if you like, is paying attention to your mental health. The difficulty, of course, is that where people have tried this before, and it's only been done in a small way elsewhere and not in PSPs, is that the people who you really want to see every year, you don't turn up. That's part of the problem. But it's one of those things which it's one of those trials, it's one of those studies which needs to be done, because I don't know the answer to that. I'm usually a bit skeptical about it, but I just don't know.
Okay. So if there's an organization out there that wants to trial it, let us know. So based on the factors that you talked about, would you consider retirement a risk factor for PSP suicide?
Sorry, I missed the question.
Sorry, would you consider retirement a risk factor for PSP suicide?
it doesn't seem to come out as a risk factor, but it's clearly an important transition and needs to be managed well. A colleague of mine, Martin Heisel in London, is looking at this. It doesn't, again, because suicide is such a rare event, it's hard to link things like retirement to subsequent suicides. If you, having looked through all the suicides in Ottawa over a 4 or 5 year period, it didn't seem to be that retirement in general and retirement of first responders was a particular risk factor. But clearly it's an important, there's often losses associated with retirement, loss of colleagues, loss of income, loss of social support, but also a lot that's gained as well. So it's clearly not a strong risk factor. I think there's far more important things to pay attention to, but I mean, it's a good point.
Okay. Next question is, how often can a PSP who's attempted suicide be successfully reintegrated back into their workplace?
Who do you have in mind? I can't give you a number, and it depends what their role is. It depends what the circumstances are. Depends whether they have access to lethal means at work. Depends what package you can put around people. Depends what treatment they've had. It's a bit like saying, how many heart attacks can somebody have before they can go back to work? Well, it depends. Some heart attacks you don't even know you've had a heart attack. Others you end up having significant surgery and being off for months at a time. So the unsatisfactory answer is that it depends.
Okay. So this is a note from a PhD student who's interested in doing research in the area of PSP mental health, and they're wondering what you think are the areas of research that can be most useful to inform clinical care.
The stuff which is unique to public safety personnel is the I think the effects of being disciplined, the effects of being either inside or outside the herd. I keep on saying the herd because that's how people describe it to me. I don't know whether that's acceptable, but I think I can convey what I mean. And the effects of organisational policies on first responder suicide. Those I think are some of the more important things. The third thing we're doing as part of the Sept suicide prevention group is actually coming up with a PSP strategy for suicide prevention amongst public safety personnel in Canada. So that will help answer that question.
Okay. Next question is, what's the best way to contact you if people want to directly share their ideas? Is there an email we can share with when we post your presentation?
Yeah, I'm really sorry. I usually leave a slide up with that on. So the best email is shatcher@toh.ca. So it's shatcher@toh.ca. And one of the things, as I mentioned, we're doing this study in Ontario at the moment. And one of the things I would ask this group is if you know the name of anybody who died by suicide, who was a public safety personnel in Ontario between January the 1st, 2014 and the end of 2018, I'd be really grateful if you could contact me and let me know their name in confidence. This is a study which is funded by CIHR. It's got ethical approval. We've got the names of about 35 first responders, PSPs, who died by suicide over those 5 years. I don't think that's everybody, but the only way we can find out if we've missed anyone is basically to ask groups like this, do you know anybody else? So if people do know of anybody who died by suicide in Ontario in those 5 years, we're really delighted to let me know in confidence. And it's shatcher@toh.ca.
Okay. So the next question is there a possibility to have a voice at the table for creating the Canada-wide guidelines for PSP after suicide? Now, I'm assuming perhaps that is, will there be PSP voices, or will you open a call to have PSP voices?
Absolutely. I'm a great advocate of nothing about us without us, and there are already PSP reps involved with this. But if you're interested in being involved, drop me a line. They're already at the table. I wasn't going to do this without involving people, without involving PSPs.
Okay, perfect. And I will just let everybody know on the call, when we post this video, we will also post Dr. Hatcher's contact information if you missed it, so that you have it and it's attached to this presentation. Next question is, our peer support group has taken Assist. What other suicide prevention training can you recommend and would be beneficial for those assisting first responders?
Well, Assist is good. I mean, it's a commercialized product. It costs money. There's, I think, the same company. It's LifeWorks, isn't it? I think they do some additional training. The trouble with one-off training is that it often needs repeating. So I would make sure that in your organization that people who are new to peer support get the training. I mean, it's a worthwhile training to have, and that the training is updated on a regular basis.
Okay. So a suggestion from Kathleen is that as an ER nurse of 35 years who's worked with many terrible traumas, a group you could compare with PSPs is ER staff, physicians, and nurses. She's personally lost 3 physicians and 2 personal friends to suicide. So perhaps when you're looking for a comparison group, they might be a good group.
Yep, and of course, doctors and nurses, and especially in some of the some subspecialties in medicine, are at higher risk of suicide in the general population, and it's a very similar story about occupational health and the overlap with suicides. And of course, one of the higher risk groups are psychiatrists.
Okay. So do you have a couple minutes to stay after 12, or do you have something you have to go to right away, Dr.
Got a couple of minutes.
Okay, I'll ask 2 more questions then. The first one is, what do you think there is the possible role of secure digital mental health in helping with treatment for possible suicides?
Yep. So we've done studies on this, and there's lots of advantages to digital health, and we're actually doing a study at the moment where we're combining face-to-face therapy with sort of electronic case management and an app that people have. And once we've done the study, I'll let you know if it works or not. But yeah, digital mental health is really digital tools or therapy delivered electronically, digitally, can be very useful. It works best when it supplements seeing somebody. Excuse me, when you see it supplementing seeing a clinician. On its own, it's not particularly effective. Mainly because people just don't carry through with it. There's nobody to be accountable to. But if you do it in conjunction with seeing a clinician, it's more effective and can certainly be helpful.
Okay. Just a couple last questions from me, actually. One, are you willing to share your PowerPoint with the audience?
Yeah, no worries. No worries. Yep.
Okay, then you can send it to me and I'll post it with the session. And the last one is, we do have some outstanding questions. Are you okay if I forward those questions to you?
Oh, please do so. Yeah, please do so.
Anybody who had questions and that weren't answered, your email information is going to be recorded with the question. So I will forward them to Dr. Hatcher for him to provide you answers. Obviously, don't expect them tomorrow. Dr. Hatcher's busy, but hopefully we can get to you within, I don't know, like the next week or so, question mark?
Yep, great.
Okay. All right, then. I want to thank everybody for being here today. I especially want to thank Dr. Hatcher for giving this wonderful session. There will be a quick survey at the end of the town hall. We hope you'll take a moment to complete it. We will be hosting another town hall in October with Dr. Greg Anderson, and he'll be exploring the impact of COVID-19 and the changing public health order restrictions on PSP and their job. We're also going to have some webinars at the end of September giving detailed look at PSPNet, which is our internet delivered cognitive therapy, cognitive behavioral therapy program. So if you want to see how that program works, you're welcome to join us for those sessions. That information will be provided in your follow-up tomorrow. Again, to everybody out there, we want to thank you for attending, and please take care and stay safe.
Thank you, everyone.
Thank you.
Okay, we done? Yeah.